Good afternoon, everyone. It's almost into the evening, depending on how you count. I'm Barbara Fain. I'm the executive director of the Betsy Lehman Center for Patient Safety. As I think most of you know, we are a Massachusetts state agency that is, as our name implies, focused on supporting providers, patients, everyone in improve the safety of healthcare in the Commonwealth. And a big, a big element of safety improvement, we strongly believe, is meaningful patient and family engagement in safety work, both in the safety of their own care, but also in supporting healthcare organizations in improving safety and preventing harm. We're excited to first of all have a new Patient Family Advisory Council (PFAC) program under our wing as of about a year ago. And the reason we brought this program in was because, just as I alluded to, we need this meaningful patient-family engagement, and we think the best vehicle for doing that is through PFACs that really have the capacity to support patients and families in contributing to this work. So, without further ado, we have a great program planned, but I am just going to turn this over to Jane Powers, who's the director of our PFAC program. And Jane, why don't you take it from here?
Thank you so much, Barbara. And let me add my own welcome and thanks to all of you for joining us this evening. I've actually had the opportunity to meet with some of you already, but this is really my first chance to connect with the broader PFAC community across the state. As Barbara said, my name is Jane Powers. I'm the Director of Patient and Family Advisory Councils at the Betsy Lehman Center for Patient Safety. This is a new position at the Betsy Lehman Center. I started in mid-January, and I've spent the last few months learning so much about the important work of PFACs in our state and meeting with PFAC leaders at a good number of hospitals. I really hope to continue to meet with many more of you in the coming months, and I am always up for sitting in on any PFAC meetings that you might invite me to join. In just these few months, I've learned so much, and I have really appreciated the creativity and dedication and commitment of PFAC members, as reflected in all those conversations I've been able to have. So I'm excited that later we'll be talking about some of the ways that we're trying to be responsive here at the Betsy Lehman Center to feedback that you've given. And we'll talk about that later in the program. But first, here is the agenda for our time together this evening. And I'll just note a couple of quick housekeeping items. This meeting is being recorded, and it will be made available on the Betsy Lehman Center website, along with the speaker's slide, within the next couple of days. So people can just enjoy the event tonight, not worry about taking any notes. We've decided to do the forum in Zoom meeting mode, not webinar mode, which means that everybody can actually see each other and will be able to engage with the speaker. You can use the chat function if you think of a question that comes up during the presentation, or you can wait until our speaker finishes her presentation and use the raise hand function and unmute to ask her questions directly.
Jane?
Before I introduce our presenter, we're going to ask a few quick questions to get a sense of who has joined us for the forum. And this is also practice for some poll questions that are going to pop up during the keynote presentation. You'll see 3 poll questions pop up on the screen. So these questions are geared towards helping us get a better sense of who's here and what drew you to attend this evening. They're for our internal use and they're anonymous. So you can go ahead and answer each one right now. And depending on your screen, you might have to scroll down a little bit in order to view all 3 questions. And then when you're done, you just click submit. Thanks for doing that, everybody. And now it's really my pleasure to introduce our keynote speaker for this evening, Barbara Lewis. Barbara is a nationally recognized expert and researcher on the work of patient and family advisory councils. She holds an MBA and is on the verge of defending her dissertation for her doctoral research project, analyzing qualitative and quantitative data from PFACs that she surveyed across the country. She has co-chaired the Beryl Institute Global Patient and Family Advisory Board and Kaiser Permanente Southern California Regional Patient Advisory Council. Earlier in her career, she worked in journalism and marketing. Barbara will be telling us more about herself in her presentation, but I just want to say how much I learned from Barbara's articles and the resources that she's developed for PFACs as I was starting in my position. You're going to have access to those resources when we make the slides available to you in the next couple of days. I've really enjoyed talking with Barbara during our prep calls for tonight, and I'm delighted to welcome and turn this over to Barbara Lewis.
Thank you so much, Jane. I appreciate that. And thank you for inviting me here, talking about my favorite subject, which is patient and family advisory councils. So as Jane said, I'm just going to talk to you a little bit about my background and why I'm actually here. I spent 2 weeks in the ICU with my sister in 2014, who had been admitted from her doctor's office of an unknown infection. And I was researching this, sitting at her bedside for 15 hours a day, living in the motel next door. I'm a former reporter. As Jane said, I worked for the Wall Street Journal. And I was interviewing people all over the country, and they were telling me things that should or should not be done with her. And I would go into the family meetings in the morning and report what I had found. But I was completely dismissed. No one listened to me. And in fact, one hospitalist said to me, "We'll take her off that medication if you want your sister to die." So, but I would find out days later from the nurses who would confide in me, and they would say, "Oh, we did take her off that medication today." But unfortunately, it was too late for my sister. And that tragic and traumatic experience forced me to ask this question: where is the patient voice in the hospital, and why wasn't I listened to? So as I began researching, I found patient family advisory councils. So I identified the council in my hospital and joined. And then, as Jane said, I was on the Regional Patient Family Advisory Council and was selected as a first co-chair of the Beryl Institute Global Patient and Family Advisory Board. I was on a conference call one day, and a woman said that her CEO would not start a PFAC because there was no evidence. And I thought, well, I've got an MBA and I've written a lot of business case studies. Let me go ahead and write a business case for why a hospital should have a PFAC. So I got a grant from the Beryl Institute and anecdotally proved that PFACs save hospitals money, they improve safety, and they enhance the patient experience. And this research was cited at conferences. People would come back and tell me that they heard about the research. And when I wanted to update this 10 years later, I thought, you know what, let me go back to school and get a PhD, and my dissertation will be on PFACs. So here's what we're going to cover today. I'm going to talk about 5 different areas that stood out in my research: support, recruitment, meetings, content, and accomplishments. And as Jane mentioned, if you have questions, you can put them in the chat. I'll pause periodically, or we can wait to the end. So I started researching PFACs, and I found this document, Crossing the Quality Chasm, published in 2001 by the Institute of Medicine, now known as the National Academy of Medicine. And it talked about a quality gap that we should close. And they identified it as 6 different areas that they called STEEP. And the last one, patient-centered, was focused on patient preferences. So I looked at the history of PFACs, and here Massachusetts has its footprint all over the place. The first PFAC that I could find was at Boston's Children's Hospital in 1982. And then in 2006, HCAHPS came along, patient satisfaction surveys, and they were tied to Medicare reimbursement. So now all of a sudden hospitals were looking around and saying, okay, maybe we need to involve the patient in talking about the discharge instructions or the communication or quiet at night. And then finally, you are my hero. I wish I could have this in every state, but Massachusetts mandated PFACs in 2010. So I've done 3 studies called Mixed Methods. I did a literature review of 143 articles that was published in the Journal of Patient Experience. And I didn't just look at the US in this one. I thought, wouldn't it be interesting if I just looked all over the world and see what articles were published? And that was quite interesting. And then I interviewed 20 hospitals in my qualitative study, and that is currently under review. And I'm just finishing up the quantitative study. I had 203 participants. So let me get into the first area of support. And as you probably know, support is really necessary across the organization. And I divided support into 5 different areas. So one is the executive sponsor, and this is the support from the C-suite, and that could be the CEO, the CMO, the CNO. Then I differentiated with champions, and those are high-level leaders that may be involved on the PFAC on a monthly basis or even a daily basis that attend that attend meetings and find content. The next one is administrators, and of course, they cover the logistics, so support from them is important. The department support is crucial because they usually bring the content to the meetings. And finally, patients and family is important because if you don't have patients and families engaged, then you won't have a PFAC. So in looking at the support, the executive support is pretty good for most of the 203 people who participated, or the respondents in this question anyway. But champion support is even better, and that's the person who works on a day-to-day or monthly basis with the PFAC. But I found something very interesting. If the champion is appointed, there's less support, and if the champion applies, there's more support. So if the CEO says so-and-so is going to head up the PFAC, that person actually looks at it as just another job that they have to do, and oftentimes there's not as much support. And this is what people have told me. But if the CEO said, we're going to open it up to anybody who wants to apply, and people who are really passionate and who are very patient-centered and want to be involved, if they apply, they will be much more supportive of the PFAC. So I took leadership and I put together those 2. I put together the executives and also the champions and looked at leadership because they were very much the same in the statistical analysis. And what I discovered is that hospitals with higher leadership support were more likely to have sufficient content to fill the PFAC meetings. And that if you had higher leadership support, you also were more likely to have a pre-meeting with departments before they actually came to the PFAC. And I'm going to talk about that a little bit more. And if you had leadership support, you had a higher level of engagement. So there's 3 levels of engagements that I identified, starting first in the literature review, actually, and then proving in the quantitative survey. Stamp of approval is the lowest, and only 3% were involved with that. And that actually held across both the quantitative survey and the literature review. That's where the task is already completed. The department comes in and the PFAC is supposed to give their stamp of approval. Then with feedback, the initiative is brought to the PFAC, but it's on input on a project that's already in process. And finally, the highest level of input is co-design, and that's where the PFAC is involved at the inception of the project. So some people told me that their PFACs ban the stamp of approval. And one person said to me, this is not respectful of bringing in a department and just saying, give us your stamp of approval, but not using their feedback involving them in the project at all. Throughout this presentation, I'm going to use these red circles, and they indicate best practices. But what happens if you don't have a CEO who's supportive? Now, because it's mandated, your CEO probably is supportive, but maybe not. So a couple things to do before the new person is selected. So one is you can have PFAC volunteers on the interview committee. And I was actually asked to be on that interview committee to interview the new incoming VP, who is the head of the PFAC. And of course, my questions were all around patient-centeredness. Or if the board is selecting the person, to make sure that they are looking for a patient-centered person, a new CEO. And then if you can't be involved at the beginning, and I'm looking at possibly your PFAC bringing somebody from out of state who maybe is not that familiar with the law and the fact that you have to have one, but then you can meet with the new CEO and talk about the accomplishments. And I'm going to sound like a broken record, but I'm going to talk about metrics a lot during this presentation and how important it is to prove the value of the PFAC, even if you are legislative. It's all about measuring, measuring, measuring. So let me just pause there for a moment and see if there's any questions about support in the chat. Anything?
See any, Barbara?
I don't. Okay, let's move on then to recruitment and onboarding. And again, the red round circle is best practice. So does your PFAC have a focus or not? You know, is it a general PFAC or is it focused? Well, in literature review, I found that 70% of articles from around the world, the PFAC had a focus. Either they dealt with a specific condition, or they focused on a specific person, or both. And statistically, I found something really interesting, that if the PFAC had a focus, there was likelihood of more content that was brought to the PFAC, a higher engagement level from maybe feedback to co-design, that there was more coaching and training of the members, and there was also an increase in process and outcome measurements. And those are with PFACs with a focus. So the question, how well do the demographics of your PFAC match the hospital's demographics? Not very high, actually. And here are some of the methods used to recruit members from 2% to 20%, all these different ways. And I actually have more ways on my website as well. But I'm finding that more and more people are matching their hospital demographics by using the electronic health records and looking for specific people. So here's a recruitment challenge. In the interviews that I had, I found 3 hospitals had closed their PFAC due to disruptive members. Now, this is 15% of PFACs were closed in the interviews that I had because of disruptive members. And here's a few solutions. So number 1, interview the candidates, and some hospitals don't. You raise your hand, you want to be on it, you're on the PFAC. So interviewing is important. Making sure that those people don't have an axe to grind or they're not angry about their hospital experience. A discussion with the patient's doctor is important. And one person told me that when they reached out to the clinician, they said that the last time the patient was in the office, they had to call security. So making sure that the clinician agrees. Also checking litigation. I heard a story of one person who tried to be on the PFAC because they were in litigation against the hospital and they wanted to learn more about what goes on in the hospital through the PFAC. So checking litigation and making sure nobody is there for that purpose. Also having a trial meeting, allowing the person to be in the meeting before being invited. Do they find themselves as a good fit for them? Do the PFAC members agree? Documents such as norms, which define the decorum and the behavior, are important. And some hospitals have people to sign these documents. And finally, coaching, and I'm going to leave that for a little bit later. The benefit, of course, is a productive council. So I was very surprised to hear that most members do not attend a council meeting before invited to join, which I believe is a best practice and should be done, because you do want to find out whether or not there is an axe to grind, and that may preclude other problems. Here's the average number of people on a PFAC according to the quantitative survey. Is there a defined term of membership? Yes, but still 1/3, almost, yeah, 1/3, more than 1/3, don't have a defined term of membership. And this is one of the problems that the 3 PFACs that closed had, because they couldn't rotate anybody off. They were just there forever. And so they decided to close down the PFAC and reconstitute it with new rules and regulations in place. And the duration of the term is 2 years, to almost 2/3 of, say, 2 years. But I advocate for 1 year just because of this issue of rotating people off if you find that they are disruptive and you can't deal with it for some reason. And then there's an application process after 1 year, and the people can keep re-upping. So let me pause. I don't see anything in the chat. Jane, any questions about recruitment?
Not that we have a raised hand. Karen, would you like to unmute and ask your question?
I would, and this is great, and this is answering a lot of my questions. So I work at Leahy Hospital and Medical Center, and I'm also responsible for the patient liaisons, which handle our patient grievances. And I wondered how to integrate that work into this work in terms of recruitment. And I guess my question is, or it's okay to do that then? It's okay to have a conversation with a patient who has a grievance, or even if a patient, sometimes we get, kudos. So it's okay to a patient who has a grievance, it's okay to ask them to maybe think about joining our PFAC. I was given information that might not be okay, but it sounds like it is.
No, that is absolutely a good idea. And that's where a lot of people come from, the grievances. And it can be both, good things and bad things. The problem is that you just can't take an aggrieved person and put them on the PFAC. You need to have that interview, because then you'll find out whether or not they are mad about this. Some people like me, I didn't look backwards. I only looked forwards of what I wanted to do. And I wasn't mad. I wanted to actually help the hospital improve. And I did start a PFAC with my sister's hospital, actually. So I think that's a great idea, but there have to be guardrails in that you have to interview them and then go through all the other steps. Are they in litigation? And that would be very important for a grievance to find out. And I see something else in the chat, Jane, and then we'll move on.
I think you can move to the next section.
Okay.
Thanks.
Great. Okay, meetings and engagement. So how does your PFAC meet? So this was done in March of this year, and over half are still hybrid, which is really fantastic in my opinion. I did find that there were some PFACs that were only in person, and can you guess which these might be? Yeah, the geriatric councils. They may be technology challenged, and they might want to socialize a little bit more. So the idea of hybrid, though, allows more people to attend, and there's much better demographic representation. So hybrid is always great. How often do you meet? Monthly was the predominance here. I have been on 4 or 5 PFACs, and I was on one that met every other month. And I just found that there was no momentum there every other month. I just, what did we do before, and where did we leave off, and things like that. So I think that every month is really great. How long? An hour and a half. And what time? Most start in the afternoons, but if you're trying to attract people who are working, a night might be good too. And still 40% are starting at 6 p.m. or after. How frequently do you provide training for members? This is sort of sad that, only 1% or less than 15% are often or always here. And I'm going to talk about specific training. How often do you work privately? Never. Oh my gosh. As always, which is sort of surprising as well. Okay, so let me get into that a little bit. So the operation is pre-meetings, during the meeting, and post-meeting, and that's sort of how I've divided this up. So how often do you have pre-meeting with department before they present? Only 15% are always, but let's talk about why this is important. So first of all, you view the deck, right? And when I was the co-chair and having pre-meetings with departments, sometimes the deck would come in with 20 or 30 slides in them. You know, let's talk about the history of this department and all the things that have happened and the various clinicians that work here. No, we want a deck of 5 slides or less, with no acronyms on the deck, or it said actually. And what are the questions for the council members? And are these questions appropriate? And I have met with departments and just have said, no, you know, this is not what the PFAC does, and answer these types of questions. So you want to make sure that there's good questions and then decide whether or not there's any pre-meeting homework. So in the PFAC that I was on at Kaiser Permanente, there was always pre-meeting homework. And this was the agenda that was distributed and also the questions that were going to be asked. And I love this because not only didn't have to talk off the top of my head, okay, here's the answer to that question, but I actually had some days to think about this. And I have to tell you that my answers changed when I ruminated on these various questions. Okay, let's talk about during meeting then. What are some of the things? Well, training people is really important. And I happened to ask somebody who had 10 PFACs, what was the most successful PFAC that he had? And he said, oh, by far, it's the one with all business people on it. And I realized that a lot of PFACs don't have business people as members. And what happens with business people is they get through the agenda, the timing, they know how to tell a story. And so my colleague and I on the PFAC decided that we would teach storytelling in 2 different ways. One, I was the roundabout person who talked, and she was going to be the problem solution benefit person. So the problem is that I'm sitting in the exam room and the surgeon has his back to me and he's looking at my x-ray and he says, oh, this looks like it could be cancer. I'm going to run some tests. And the solution is to have the surgeon turn around, face me, and say, I've looked at the x-ray and we're going to run some tests and nothing to worry about. True story. He told me later there was nothing to worry about. And the benefit, of course, is that I don't worry myself sick for 2 weeks, which I did. And plus I almost fell off the exam table. Okay, my story, now I'm the roundabout person. I say, well, I got up in the morning and I got my kids off to school and then I got in the car and I got to the parking lot and I couldn't find a space. And this is not an exaggeration. And maybe you're not facing this, but I have heard this many times where it takes 5 minutes for somebody to get to what happened in that exam room. Using a round robin where you ask the question, someone raises hand, call on that person, and then go around. And this ensures that everybody has a voice and that the shy people aren't overwhelmed by the talkative people. If you don't have anything to say ditto, nothing to add, or LMO, if you hear a long-winded narrative, let's move on. And now let me talk about coaching the volunteers. So I found in my interviews that closed the 3 PFACs that they did not know how to coach volunteers, and they did not. One person, on the other hand, said, I relish this. I want people in my office who have behavioral problems, and I want to coach them. So case in point, she told me about this woman who had a very harsh effect in the meeting that the other members didn't appreciate. And she sat down with the person and found out that she was on the spectrum and told her how the perception of what she was saying, and she didn't know. So she tempered what she was saying and she held back oftentimes and didn't just jump in, blurt out, and sound as though she was mad. Another example of a coaching situation is an older gentleman who came to the meeting and complimented all of the women. Oh, I love your hair. That's such a great color on you, the dress. And, you know, people who were his age would probably say, oh, thank you so much. But the younger members felt that this was very creepy. And he said, I had no idea how my comments were landing. And so he just stopped doing this. Okay, how often do you have enough content? This was really great. My gosh, almost 90% always or often have enough content. And the higher visibility that you have, the more content that you have. And this is what I found, that if the PFAC is promoted throughout the department, throughout the hospital, you're probably likely to get more content. Annual goals split 50-50, surprising statistic here. I mean, everybody should have some goals because you can't manage what you don't measure, and hopefully you all do. And those goals can be SMART goals: specific, measurable, achievable, relevant, and time-bound. Okay, so now let's talk about one of my favorite subjects, and that's metrics. You know, can you identify the impact that your PFAC is having and the value? So there's 3 different types of ways that you can measure. One is that you can get the feedback from the presenters. You can get the feedback from the members who are in the meeting. And finally, you can measure the initiatives. So let's break those down. There are 3 types of measurement according to the Agency for Healthcare Research and Quality. One is process, and basically that's about the activities, and that's usually a number: the number of meetings, the number of PFAC projects, the number of people, the number of new people, the number who rotated off. Then the second one is capacity, and that is not frequently used in PFACs. But the third one is the gold standard, and that's really a best practice, and that's outcome, and that's doing pre and post measurement. So take this procedure, for example. There were a ton of cancellations, and I'll share that it was a colonoscopy procedure, right? And those directions are numerous. So people were getting to the reception area, and they asked, did you follow did you do this? No, they didn't. So they had to leave. And then they brought the directions to the PFAC. The PFAC changed it 180%, as one of the departments said, as one of the members said to us, and revised. And now what is the difference in the amount of cancellations? So here's 3 different, well, actually there's 8 different types of projects that were done. 3 of them could have had measurement, but in the interviews, none of these had measurement. And this is sad that people are just not measuring the before and after of what they're doing to show the value of the PFAC. So how often do you obtain feedback from the departments? Always. Very low here. Oh my gosh. Always should be asking the departments about their experience. And is it quantitative or qualitative? Mostly it's qualitative. So we're asking them questions, but it should be both. And here's an example. So on a scale of 1 to 5, quantitative, how would you rate the following? So now we have numbers, and we can compare this year's numbers with last year's numbers, for example. Or in a few sentences, the qualitative survey, how would you describe the benefits? And this is where testimonials come in. So having some kind of a survey like this is really important to give to the departments. So anything, Jane? Should I move on?
I'm keeping track of a couple of things that have come in, Barbara, but I think I'll save them for when we open it up, and I'll start us off with a few that have come in while you've been speaking.
Okay, great. So let's go on to accomplishments and impact. So how do you promote the accomplishments? So newsletter, presentation, report. 8% are not promoting the accomplishments of what's happening with the PFAC. And how often do you promote? Well, annually is the big winner here, but it should be monthly. So on a monthly basis, you could say this department came to us and asked us these questions, and we had feedback, and this, you're talking about this month. And then another article on 4 months ago, this department came, here's the feedback that we gave to them, and here's how they changed what they were doing. So I'm advocating a newsletter or a presentation or something on a monthly basis. Again, more visibility gives you more content. And although there's not a lot of PFACs that are missing content, you still could have more content and more widespread support among the departments. How frequently is a department's implementation shared with the council? Less than 1/3. And someone told me that one of their best members was leaving, and she was so upset. And she had an interview with them and said, "Why are you leaving?" And they said, "I don't know what happens to my input." I talk about what I think you should do, and I never find out what happened. So it's really imperative to close the loop so that you don't lose members' interest. The organizations that are relied on, the Barrel Institute is a big one here, but that is a membership organization. So I have found the Institute of Patient and Family Centered Care at 62%. They have a tremendous amount of information for PFACs. It's all free. And last time I was on their website, I think I counted 40 different documents that they had for PFACs. Okay, let's do a poll. How often do you track process metrics? And you'll have 6 choices here. And go ahead, and this is the number one, the number of meetings, the number of initiatives, the number, please fill in that. And okay, I see that we have only 33 people out of 100 here who participated. Go ahead and fill that in. Wait a few more seconds for people to. Okay, is that about good? All right, so it's split pretty much across the board from never to always. How often are you tracking process metrics? Okay, let's see what the. Okay, I had somebody drawing, I guess. How often do you track process metrics? All right, so 1/3 of them are always. So that your always was only 17%. So nationally, this is a little bit better than you, but this is the best practice that you should be keeping track of the number of meetings that you have, the number of departments, which departments, the initiatives, etc. Process metrics are very important for proving your value. Okay, how often do you track outcome metrics? And this again is things like the improvement in the patient experience scores or the reduction in the number of falls. And it's up. And again, we have the same 6 choices, never, rarely, occasionally, sometimes, often, always. And let's see, 20 and 30 of you have participated. If you can fill that in so that we get a fairly good amount of people who are attending. And okay, so should we share the poll? All right, again, pretty much across the board, 20% with never, 10% always, but in the teens for the most part, except for never. Okay, what happened in the US? All right, outcome is 10%. This is exactly the same as you, and never is 22% here in the survey. And yours is 20%. Okay, so it's very important to track outcome metrics. All right, so let me tell you a story. I was so thrilled when I could review the annual reports at the Massachusetts Hospital, and I've done this twice now. I looked once a couple of years ago and read all the reports, and then a few years before that, I read all the reports as well in the fall. And there were quite a few reports in both instances, but there was not one outcome metric in any of the annual reports that I read both times. There were some process metrics. And as a matter of fact, somebody said, we need to start measuring. In the report that was submitted at the time, it went through Healthcare for All. That's where I had read all of the messages. So how about this one, our third and final one? How often do you measure the impact of the PFAC on initiatives? And let's see, again, same answers, never, rarely, occasionally, sometimes, often, always. And we have, oh, good, a lot of people participating in this one. Please participate. Remember, this is anonymous, so nobody knows who you are if you say never, that you don't measure the impact. And I think that's probably a good place to stop, I should say. And we can see that 23% are never, and 9% are always. And so always is the best practice here. but most people are not doing this. Often is 13%, it's 29% in the country. So why are metrics important? And maybe you think that metrics are not important to me because I'm legislative and I don't need to worry about proving my value. But let me talk about the different ways that metrics are important. So let's look at the PFAC ecosystem. So patients, why are metrics important to patients? Well, you can turn around and use a improvement, for example, food. We went from 50% approval rating on the, if that's, you know, one of your Press Ganey or HCAP questions, to 95%. Okay, patients are going to want to use that. Do you have a patient-facing newsletter that you can put this information into? That's a competitive advantage for you, and that's good information to have. Okay, how do you want to grow your hospital's number of PFACs? Now, one hospital I spoke to had 30 PFACs in one hospital, and maybe because you're legislated, you only have one, that's all you need to have, but maybe you should want to grow them. And if that's the case, then you want to prove your value and say, okay, we'd like to have a PFAC in this department or in that department or among the youth or whatever the case may be. So proving the value. Sharing the metrics and your improvement with the community in Massachusetts hospitals, again, with the community, if you can have an article in the newspaper or something like that, that's a competitive advantage for you, and sharing it with the US hospitals and the world. So I said before that you are my hero, and I look at Massachusetts as a lighthouse because you are the leader in embedding the patient voice in healthcare. And you can also be a leader in the measurement here and showing that hospitals do need to measure to prove their value. So I've got an article on metrics that came out in the Journal of Patient Experience called Success of Patient Family Advisory Council, The Importance of Metrics. And I'm going to be speaking at the Patient Experience Symposium in Boston on October 6th through 8. And here is a QR code and the link to this. And it's a rather expensive conference, but if you're a small hospital, they have told me that they do give discounts. They're not giving automatic discounts to everybody, but if it's too much for you to pay, see if you can get a discount. Okay, 7 takeaways here. 1, solicit leadership support and carefully select members. Include the virtual modality to increase demographic representation and reduce the budget. Increase member engagement by closing the loop. Measure the initiatives and feedback both quantitatively and qualitatively, and use process and outcome measurements. And finally, promote your measurements or your accomplishments, I should say, frequently. So I'm going to be having webinars on going in depth to a lot of this information. If you want to be put on the invitation list, here's my email address, blewis@healthcarepx.org, my nonprofit, and just go ahead and send that to me. And Jane, over to you.
Thank you, Barbara. That was so much information. It was jam-packed. But I'm very happy to say that we have about 15 minutes now for Q&A, question and answer. And we're going to try to get to as many questions as we can by 6 o'clock, at which point we're going to transition to the next part of our forum. So I have collected some of the comments and questions that I'll start us off with, but if you would like to ask Barbara a question, you can use the raise hand function at the bottom of your screen. And to raise your hand, you want to click on the reactions button found in the toolbar. For most of us, that's going to be at the bottom of our screen. And then you can select the raise hand icon. And I'll be trying to keep my eye on the audience I'm gonna start us off, Barbara, with a couple of questions. One is about attendance. Do you have any recommendations for addressing poor attendance among PFAC members?
So a couple of things. One is that some PFACs have a ruling, and you sign this on the document when you first become a PFAC, that you have to attend so many. And if you miss 3 meetings during the year that you will be rotated off. So it's important to have everybody there, but I think more importantly is the PFAC that is missing members. Are they coming back and having the conversation of what happened 4 months ago? When this department came in, here's what you said, and here's how they changed. You know, that feedback loop is really important. Otherwise, patients lose interest in the PFAC. So that could be an issue.
Thank you. Another question, you mentioned training for PFAC members. Is that only for participation in meetings, or are there other kinds of training that would be helpful?
Well, most hospitals have some kind of training that is mandatory. I mean, a TB shot if you're in the hospital, or, you know, different types of training that I've gone to in the past regarding employees and different things like that. But any problem that you're facing in the PFAC that you can turn into some kind of training would be good. And this is how that dual video came about with the Wanderer and the problem solution benefit, is because people were just wandering around and speaking. And I'm coming from a business standpoint, and I'm saying we have got to do something about not being able to get to the point for 5 minutes. So what's the issue that you're facing? And then develop a training around that. And one of the most important trainings for the hospital employees is conflict resolution. How do you coach people and talk to them? And it seemed like the fact that the 3 PFACs that closed, those people didn't want anything to do with coaching. So that's important on that side. Did that answer that question?
I think so. And maybe another idea actually came via a question. Somebody said, could you give examples of annual goals? Well, that would also be a great thing to train PFAC members on. Goal setting.
Goals.
How to do that? What do goals look like? But how else might you respond for possible examples of annual goals?
So one of the other training that I have done in the past is to talk about metrics. And I've given this presentation to a number of hospitals, the importance of metrics and how to look at the metrics and how to, you know, the 3 people that you should be measuring: the department, the patient, and the initiative. So a goal might be to, you know, you want X amount of meetings. Okay, that's really a good goal. You want to recruit X number of people. You want to use the following recruitment methods as a goal to find new people. You want to improve the patient experience scores in discharge directions, for example, because you're arranging with the discharge department to come and you're going to give input on that. Or that's very specific. You may want to say, we want 12 departments to come to us to talk about their issues, and we want to make X presentations to departments to let other departments know about the departments that are coming to us, what our feedback is, and how they're changing, to get other people on board with bringing initiatives to us. So those are just a few ideas for annual goals.
Well, let's turn to some of the hands that are raised. We'll start with Kevin. We'll invite you to unmute and ask your question.
Thank you so much. That's I really appreciate this forum and applaud the work of the PFAC at Tufts for encouraging and supporting our participation in this very valuable resource. I'm curious to find out, Barbara and others, if there is a sense or a current happening in the field, particularly in hospitals and in patient care departments, and discussion about any kind of changing roles of PFACs in light of perhaps some of the funding cuts or changes that might be coming down the pike vis-a-vis Medicare or other changes afoot with a very different view of health and human services that we have under, a new presidential administration.
Well, I don't know whether or not they're because of the funding cuts, but I will say that what I found in my research is that there are many PFACs that are being supplemented with e-surveys, e-advisors. So for example, the hospital may want to, and this happened in 2 cases of people I interviewed, the hospital wanted to build a clinic in a certain area. So they looked at the demographics and reached out to the people through the electronic health record in that area and asked them about building an infusion clinic or something like that. And in both cases, the hospital saved $1 million because they did not build in this particular area that they were ready to go for, but they did this e-advisor survey. So a lot of hospitals are bringing that e-survey back to the PFAC for more of an in-depth conversation, which is really good. And another thing that they're doing is that when departments are coming to them and saying, we want a PFAC like the other departments have, and when the leaders ask why you want it, it's for one particular issue, for example. Well, we want to find out about this. So oftentimes that's a work group or that's a focus group, for example. So you don't need a PFAC, a standing PFAC for every issue that comes up in the hospital. So you can use e-surveys, which save money. And also you can use a focus group that has a discrete amount of time. They'll be meeting for the next 2 months about this particular issue.
Thank you. Now we'll invite Christina to unmute and ask the question.
Hi there, thank you. My question is about having departments come to us for feedback. In most cases, we're the ones reaching out to departments saying we have this issue that we've addressed. How do you encourage departments to come to you and say, hey, we're working on this and we'd like your feedback, as opposed to us saying, we've seen this problem happening at our hospital, can someone come and talk about it?
So that is something that I found in the interviews, that there was a correlation between the people who were looking for content and couldn't find it and their visibility. So are you out there? And it's sort of a rhetorical question, but are you out there? Are you in a newsletter? Are you making presentations to other departments and letting them know what you're doing? Departments that haven't come to you yet. Are you giving presentations in the hospital newsletter, for example? So that visibility that you have is directly related to the amount of content. So if I were you, I think I would examine your visibility strength and find out whether or not that can be improved. And if it does, I can guarantee you that you will have more content.
Now, we've tried to have more visibility, but we get pushback saying that our marketing department only has so much room to put content out, and we're kind of at the bottom of the totem pole. So I guess it's more having leadership, I'm guessing, give us more visibility or fight for us to have that visibility too.
Right, and this is visibility that you don't want outside the hospital. This is internal.
No, this is internal.
But internal. Okay.
But even then, we get pushback. So
going to the different departments and using this information or whatever information data that you have about how great you are to talk to the different departments. And that's worked very well for people who are looking for information, for initiatives to come to them. Right. The other thing is that leads often attended other department meetings, and there's no mindset. Let's ask the patient about what they think. This is something that, even though it's been around since 1982, is relatively new for a lot of hospitals. And the lead sitting there will say, oh, that's a perfect thing to bring to the PFAC, to ask them. You want patient input. And they'll say, oh, right. So the leads then went to all of the different departments with their monthly meetings, listened to what they were doing, and then invited them to come. And that increased the content quite a bit. Are you doing that, Christina? Did we lose Christina?
I think, Barbara, why don't we move on to Penny?
Yeah,
we have
sorry,
just-
I was just trying to unmute. No, we don't have the ability to do that right now, but I'll suggest that.
Thank you. Okay, Penny, we'll invite you to unmute.
Thanks very much for the great presentation. I have been a past PFAC member of Dana-Farber, and I am currently at Mass General in the emergency department. The comment I wanted to mention, it's really not a question, is in terms of visibility. What we found, especially at Dana-Farber, was we very seriously looked at the goals of the Institute. And then when we put down our goals and our accomplishments, they were all tied back to the goals of the Institute, which made us get a lot of visibility because we were trying to, enhance the goals or fulfill the goals. So I think it's very important to be aligned with the goals of the hospital or the Institute and work to try to make those happen. The only other thing I wanted to mention is, again, we also were liaisons with departments. And so we'd go into those department meetings. What we did was we turned those into projects where we could help, obviously with the organization backing us. And then in terms of our results, we showed where we were with the projects and where we were completing them, and the appreciation from the different departments that we took that role on for them. So those were things that I think helped us in terms of visibility.
Yeah, that's a great point about the goals. That's very important in building your goals underneath what the goals are of the hospital. But one of the things that worked very well for one of the PFACs that I was on is that the executive sponsor, who was the vice president, told me actually that anyone who comes into his office with a project that they want to start, he always asks, where's the patient voice? So when you have that kind of support from the executive saying to everybody, where's the patient voice? We have a PFAC, a built-in patient voice here. That really helps. Everybody then wants to go to the PFAC because it's coming from the VP. Thank you, Penny.
We've got two best practice questions, Barbara, and I think that'll close out our question time.
Okay.
So one, is there a ratio of patients to employees on a PFAC that would be considered best practices?
No, there's no best practice for that, but you can see on the average that it was 13-7. So in no means should it ever be more hospital employees than patients, because that feels overwhelming to patients, what I found. But I don't have a best practice on that. Next.
And are there any best practices around the PFAC reviewing patient data, such as Press-Ganey surveys, for example?
Best practices?
Mm-hmm.
No, I don't have best practices, but that by all means is important to review the Press-Ganey reports, because what's happened is that for example, one Press-Ganey report was on the food, how low it was, and the PFAC looked at this and said, let's give them our input. Let's have dietary here, let's eat the food, let's give them, and then it went from very low to in the 90s, as you saw on one of the slides. So it's important to read those and to find out where you could have some kind of an impact.
Thank you. And we have one more raised hand. Kevin, you have the last question. We're going to invite you to unmute so we can hear you.
All right, so my question is on recruitment. I'm at a co-chair at Encompass Hospital in Braintree. And recruiting, we've tried different methods of recruiting. We have a dinner, success dinner at the end of the year where we try to recruit people there. We send out flyers. But we haven't really come up with a good recruiting process. I was wondering if there's anything that you have done that seems to be really successful in recruiting.
Well, I think that it depends on the hospital. Different things work for different hospitals. So one hospital told me that they had a huge success of putting a table outside the hospital and people walking up. Others had success at farmers market, for example, having it there. These are just some of the ones that are up on the screen now that people said that they used, and I have more on my website as well. But grievances, cafeteria, posters, and
Yeah.
somebody I spoke to recently said that it's just emails. Sending out emails to the electronic health records of people that you're interested in, or by condition or particular type of person, and asking them if they want to join. So email has been very successful. You just need to tweak this enough to find out what works for you. After visit summary, to me, that's a great idea if people are reading it, but maybe nobody reads it. Maybe they end up in the garbage can afterwards. So,
Well, I'll just
That's
share, Barbara and everyone, that in some of my conversations in talking with hospitals, we have several hospitals in Massachusetts that are actively using and finding enormous success with after visit summaries as a way to collect potential PFAC members. I had one hospital tell me that they had more than 200 people respond via an after visit summary over a month's period of time. And what that meant was that the hospital staff person then reached out to those people that had said that they were interested, but it ended up as a boon for recruiting. They're now onboarding more than 10 new PFAC members because of that. And that's something that just wouldn't have been possible without that as an additional way of looking at recruiting people.
I had people tell me that they went to the wards, the pediatric wards, if they were looking to fill their pediatric council on Mother's Day and Father's Day, and talk to the parents, and were able to recruit a lot of people that way. So there's a lot of ideas, but some things work better for some hospitals than others.
okay. Thank you.
Thank you, Kevin.
I really want to thank everybody for these great questions. And again, thank you to our fabulous keynote speaker, Barbara Lewis. If you have questions that we did not get to, or you think of any now, you can write them in the chat, and we'll work on getting you answers that we'll provide later in writing. But we're going to use the rest of our time tonight, just about 12 more minutes, to share a first look at the newly revised annual reporting form for Massachusetts hospitals to use when your hospital submits its annual PFAC report to the state through the Betsy Lehman Center. We have gathered a lot of feedback about this form, and we know that in the past it felt like a burden. It was long, and people wondered, I'm doing all this work to fill out the form, and it gets posted, but what actually gets done with the information? So we worked with 6 hospitals to help us pilot this form. We got a lot of input from our PFAC advisory group members. And then our presenter tonight, Barbara Lewis, had a look at our draft, and she advised us to include more data fields in order to improve our analysis of the incredible work that all of you are doing as Massachusetts PFAC members. So with thanks to everybody who contributed to the process, we're able to bring you the new form, and it's half as long as the old form. So we cut it in half in length, and it has a lot more drop-down menus to help us collect more meaningful data, like you've heard Barbara describe. Some of the questions may even look a little familiar. The new annual report will be available online sometime next month in June, and we will go live on July 1st with the usual report deadline of October 1st. And what is going to be new this year, in appreciation for the work that all of you do to gather and submit your information for your report, the Betsy Lehman Center is going to be developing a summary about what the aggregated annual reports show across Massachusetts, as well as preparing an individual summary that we will make available back to your hospital PFAC, something that you can share internally in your hospital community in order to showcase the work of your PFAC. There's going to be more information to come as we develop what that looks like, probably by the early fall. But without further ado, here is a quick walk through the new form. So I'm going to share my screen. And Whitney, can you just tell me if you can view that?
Yes, it's perfect.
Okay, great. This is going to be a fast look at the form, hot off the press. First, we have an introductory paragraph about why it is that we're collecting this important information. Remember, we collect this information and then post it publicly so that people can see the important work that PFACs are doing. You're going to start by typing in your hospital name, but then we're going to go right to some easy questions. How many PFACs does your hospital have in total? Are you a sole PFAC at your hospital, a hospital-wide PFAC, etc.? You can just click on this to tell us. We're interested in the names of your patient and family co-chair, as well as your hospital co-chair and contact information. We recognize that just because Massachusetts has a fiscal year that runs July 1st to June 30th, not every hospital does. And so we're looking for you to tell us how many members are on your PFAC as of June 30th. And of those members, how many are patient and family advisors and how many are staff? Preferred PFAC membership means how many you'd actually like to see on your PFAC. Maybe you have a small PFAC, but you're hoping that it could be larger. So this is a way for you to tell us what your ideal PFAC membership would look like, excuse me. We're interested in hearing if patient and family members of the PFAC are subject to term limits. And if so, to please tell us the length of the terms. We give you a drop down there. What recruiting efforts does your hospital use? We just talked about recruiting. This will help us to keep track of who is using what. How often does your PFAC meet? And how do you typically convene? Is it in person, virtually, or a mix? We've given you open boxes to tell us more about that if you'd like. And here are those 3 ways that Barbara shared with us tonight, ways that PFAC members can engage with initiatives that are presented. 1, through approval only. They're coming to you on a completed initiative and just looking for that approval. Feedback, the department asks for feedback on a project that's already in progress. Or co-design, if PFACs are involved from the very beginning of a project, you can tell us that. We've also given you a box to tell us more if you've selected something that didn't really fit into one of those boxes. The next section is about the community that your hospital serves. And one of the things that we've done this year, as we look to collect information on the racial and ethnic makeup and the languages that are the primary languages spoken of your hospital, we've given you some links here where the person filling out this form can click on this link and you'll be brought to a table that will give you the racial and ethnic information for your community. And if you come over here to patients served, you'll go to a different table that will give you the demographic information on race and ethnicity for the patients that are at your particular hospital, not just in the city or town you're in, but for your hospital. We hope that makes it easier for you. For languages spoken, we're looking for this information as we do every year, and we're suggesting that the best source for this is not going to be through a table, but through your own hospital. This question, how do the demographics of your PFACs match the demographics of your own hospital's patient population? You can tell us, is it a good match, very good match, fair, poor, or very poor? And here's a box that invites you to reflect on how you would describe your PFAC's membership representation of the community relative to the diversity of the community that you serve in a broad way, not just race and ethnicity or language, but some of these other important things that are listed here. And we'd love to hear more about strategies or activities that your PFAC has engaged in over this past year in order to better align your PFAC membership with the diversity of the community that you serve. The next section is great because it gives you a chance to brag about some of your impact and accomplishments. Here are those 3 poll questions that Barbara gave during her presentation. How often do you measure the impact of your PFAC on initiatives? How often do you track outcome metrics? Everybody answered these tonight. We're going to collect them from people across the state. And are you tracking process metrics? Then we have this box where you can tell us about some of the key work accomplished by your PFAC in the past year. And we're hoping that you'll be able to include at least 3 of your accomplishments here. How often do you promote the accomplishments of your PFAC? We heard a little bit about this tonight. Not everybody's doing a lot of it. We really want to encourage you to think about this for all the reasons that Barbara outlined. So here are some of the ways that you might promote. And if you're not, here are some ideas for ways that you could. We want to know if your hospital or organization leadership shared its goals with you as the PFAC. And did the work accomplished by your PFAC help to advance the organization's goals? And we'd love for you to tell us more about that. It would be great to hear. What were the greatest challenges that your PFAC faced? We're inviting you to tell us. Maybe we can be of support to you. Maybe we can look at ways to break down barriers that exist. Maybe we can provide some coaching. The next section is about safety. It's so important. It's important for healthcare for reasons that Barbara alluded to at the very beginning as she introduced herself. Patient safety matters. But it's also in this year where the patient safety structural measure is being implemented through CMS. Every hospital is going to be asked to attest whether they have a PFAC, whether it's representative of the community that they serve, and whether it's engaged in safety initiatives. So we're going to ask you that about your own PFAC. Were patient and family advisors represented at board meetings? Were they consulted on safety goal setting and metrics? And did they participate in safety improvement initiatives? And each of these has a drop down. We would love for you to tell us in a summary way what your PFAC's contributions are to the patient safety work happening at your organization. We think we're going to hear some great stories, and it's going to be wonderful to be able to share those back with you. Additional information, we want to know which committees within your organization PFAC members are serving on. You can just click on those. And are there any PFAC-led work groups or projects that you'd like to highlight that you already haven't talked about? And the last section, looking ahead, we want to know if you have goals for the current year. And if yes, what are the goals for the year? Do those goals support the organization's goals and priorities for the year? And if yes, how? One last box, if there's anything else that your hospital would like to highlight that has not been captured. And then finally, we'd love to know, as we've always asked, who prepared and reviewed this report. And we've got a big box here because we know in some hospitals, there's a whole lot of people that contribute to this, and we want to be able to recognize and thank everybody for doing so. So that is really a whirlwind tour of our new form. And again, we're going to make that available on our website in June so that you can take a look at it, and then it will go live as of July 1st so that you can complete your reporting back to us by October 1st. So in the last minute, a couple of quick things. We really do want to support the excellent work that you're all doing across the state. A quick reminder that our own website has PFAC resource materials that you might find helpful. And again, I'm looking forward to connecting with as many hospital PFACs as possible. And I'd be happy to be a guest at any of your upcoming PFAC meetings if you'd find that helpful. My colleague is now going to add my contact information in the chat, and you can feel free to reach out at any time. And lastly, you're going to be getting an email from us in the next day or two with a feedback survey about tonight's forum. We would really appreciate your filling it out and let us know what you thought about tonight and give us some ideas about what you'd like to see next to support your PFAC work. The slides and the video from tonight's forum are all going to be available on our website in the coming days. So please spread the word with any colleagues that you know from your PFAC who couldn't attend live this evening so that they can still watch. I want to thank you for joining us tonight, and please be back in touch with any thoughts or questions you have. And I want to wish everybody a great evening. Thanks again so much.